Good afternoon. Welcome to our next installment of Lunch and Learn. We are pleased to welcome Dr. Michael Crathen to talk to us about melanoma prevention and detection. We will be recording this so you can watch it later if you'd like. See, I have put everyone on mute, so that should be, if you want to talk or ask questions, we would ask you to put something into the chat room and we'll get to those at the end. Before Michael starts, as you know, we are able to receive CME credits for these talks. Please text the CME SMS code to the number on this screen. The code today is YUHCAH. Once again, I'll show that at the end of the screen. I am going to stop sharing. I'll let Dr. Crathen take the screen. And thanks, Michael.
All right, thanks, John. And thank you, everybody, for the opportunity to present. So as John mentioned, I'll be talking about melanoma prevention and detection, and hopefully I'll get some pearls out of this. Let's see if I can advance my own slides. There we go. Okay, I have no conflicts of interest, and there will be no FDA off-label discussions here. I was asked to put this in here. If there are referral requests, you can work through either Epic to myself. There's also the order you can place as usual for specialists, and through Epic, and we work the work queue. You can always send me a message on Epic. You can email me on my partner's email, or you can call me on my cell phone, especially if you have trouble getting somebody in on somebody urgently. But in general, I think the team, and you see the team listed here with Lori, Alejandra, Courtney, two Julies, and usually we're able to facilitate pretty nicely. Just to show you too, this location, we're at the corner of Route 9 and 27, and so very convenient for a lot of our Western patients who are all funneling towards the main hospital, you can see. But just think of us as you have patients who may be coming from Ashland or Framingham or Natick or wherever else. And we opened up in October, and you can just see we have as our front desk. Actually, we have a new sign behind it as well with the logo. Okay, so now I'll just move on to the meat of the topic. So just to give an overview, so data from 2019. Melanoma is not the most deadly of the cancers out there. It's actually on the lower end in terms of incidence for deaths. About 7,000 recorded in 2019, but the incidence has increased a lot, and we'll talk about that, about tenfold over the past few decades. The ABCD criteria, which is often referred to, as you can see on the right, with the asymmetry, border, color, diameter evolving. I'm sure we're all familiar with that, but that's only about 50% sensitive for the diagnosis of melanoma. Just in comparison, you can see here, these are expected deaths for 2019 for GI, pulmonary. Melanomas, again, about 7,000, so even less than myeloma. And you can just see that for Massachusetts, the entire state is about 12,000 deaths from cancer in 2019. So it's not the most common in terms of deaths, but it does rank up there, and it's a serious malignancy of the skin. The difference is between a lot of these other, just to go back for a second, other cancers, is that you can see melanoma, and so that makes it special. And so it does give us this opportunity that if we can see the melanomas and we can identify them, then we have a lot of room to go in terms of improvement for reducing the number of deaths. Prevention really comes down to encouraging smart sun protective behaviors. That also includes avoiding tanning bed use as well. And we do that through, the basics, basically clothing, sun protective gear, umbrellas, and sunscreen. And then the other part of it is with all kind of malignancies is just encouraging healthy living. So eating well, sleeping well, reducing stress and pollution, toxin exposure, all those things are gonna help. Now, just to go a little bit into the science, melanoma is really a UV-induced, ultraviolet-induced malignancy. There are some exceptions, and so you can see, for example, like acral and mucosal melanomas, those are not going to be sun-induced, but about 87% on these chronic sun-exposed sites, so like the face, for example, that we'll see with lentigo maligna, or the non-chronic sun-exposed, and this would be like the superficial or nodular melanoma on the back, for example. These are driven by ultraviolet mutations. And ultraviolet mutations, there are two forms. You've got, basically, this is showing specific UV, what we call a signature mutation. And so ultraviolet light basically comes in and it attacks the DNA. And you can see these two cytosines are linked. And once they're linked, when the replication happens down the chain, now it's converting two Cs to two Ts. And so now you've got a mutated DNA chain. And so that cytosine dimer, basically the cyclobutane dimer, that's actually what we call a signature mutation because it's very specific to ultraviolet induced radiation changes in the DNA. Now there are other changes which actually are kind of more common in the melanomas that are non-signature mutations, but they have basically identified that melanoma is not a surprise. They're really driven through sun exposure. The sun exposure is still debated as to kind of how it comes about, but a lot of times it's identified as actually intense sun exposures, even as a child, for example, can initiate the mutations in the pathway towards a melanoma. You can see here, this is the action spectrum also for just making these UV-specific mutations in the ultraviolet B wavelength between 290 and about 300 or 320 or so is the ultraviolet B, which is actually the most active. UVB you can also think of as the bad because that's what causes the burn, whereas UVA is more prevalent, but it also does lead to DNA mutations. So in terms of sun protection, I give a few pearls. I tell patients sunscreen is the last line of defense. And I tell patients to wear sunscreen on the areas where you don't want to get skin cancer. And so that kind of sounds smug, but it really is true. And I think it does register for a lot of people because they say, well, where am I going to put sunscreen? I don't like wearing it. I say, well, okay, well, you don't have to wear it, but on the areas where you want to protect photoaging and reduce your risk of skin cancer, then those are the areas I'd recommend wearing sunscreen. Now, in terms of the last line of defense for a sunscreen, I'll make mention that there are studies, and I'll go over on this page here, that are indicating that especially chemical sunscreens have been identified in the bloodstream. So these are studies showing if you take patients and imagine you send somebody to the beach and they say, okay, I'm going to put sunscreen on my entire body except where my bathing suit is. And to apply the 2 milligram per centimeter square amount of sunscreen all over the body, within minutes, actually, a lot of these chemical sunscreens are found in the bloodstream. And so that's been reported in the past few years. Now, those studies have not indicated that that's necessarily a problem. And so there are additional studies that need to get done to say, is it a problem if you have blood levels of octocrylene? And so we don't really know the answer to that, but it's true that applying these chemical sunscreens broadly all over the body is going to lead to absorption in the bloodstream. And so just kind of going back to this other point, you know, the sunscreen's the last line of defense. I love sunscreen, I wear it, I recommend it, but you know, a lot of kind of the society is wondering, you know, is sunscreen really meant to be the sole defense mechanism for the entire body, or is it really to use in the context of shade structures, sun protective clothing, sun avoidance? And I think that's probably the way to go. The other way to go would be you know, using a physical blocker like a zinc or titanium. The chemical blockers, besides these absorption studies, you know, some studies have shown concern for environmental impact, for example, on the coral reef. And so when they do get into the bloodstream, there's some concern that these might be hormone disruptors. The physical sunscreens really don't have that same concern. The titanium tends not to be quite as broad spectrum as zinc, so zinc-based sunscreens tend to be very good for both UVA and UVB sun protection. And again, those are the wavelengths that are leading to the DNA mutations. They tend to lead to a white appearance, and so that is a downside, this kind of white chalky appearance. And so there are micronized versions that can limit that, but unfortunately that is part of what comes along with a physical blocker. Now, this comes up a lot too, is that patients will ask, you know, does it really matter what SPF I'm using? And so this is a chart again from Bologna Dermatology that shows that at the 2 milligram per centimeter square concentration, which is the FDA kind of tested dosing, for sunscreen, you hit the flat part of the curve right around SPF 15. So no, like at that usage level, the sunscreens are about equivalent. The problem though is that most patients are actually applying sunscreen not in that recommended dosage. And so maybe people put like a thin smear on, and then with the thin smear, that actually this curve looks something more akin to this. I drew this red curve, and so I wouldn't take this scientifically, but it's more akin to the fact that, your SPF 15, when you're applying, not as much, maybe 1 milligram per centimeter square, 0.5 is going to be much lower. And so then that's when actually higher SPF numbers actually make a difference in terms of the filtration. Now, the risk factors, which a lot of you I'm sure are familiar with, just for melanoma, this would be a first degree or multiple family members with a family history of melanoma, or a patient with these personal risk factors, dysplastic nevi or many nevi. Some studies show 25, some over 100, but patients who have many moles are certainly at a higher risk. Immunocompromised, red hair phenotype. These patients basically always burn, they never tan. That's the definition of the Fitzpatrick type 1. Tanning bed use has been shown to be linked to 75% increase in melanoma risk, and this intense sun exposure. So again, that intense periods, even brief, are linked to melanoma exposure, especially before age 35. And then prior radiation for childhood is also linked. Probably the patient population with the highest risk for melanomas are white males above age 50. And that's probably both in terms of incidence and also the severity of diagnosis. They tend to be diagnosed with melanomas at more advanced stages. So we went over the prevention. This is really the detection side. You've got screening programs are basically saying this is an asymptomatic person. We're just going to screen them for melanoma. You have problem-driven detection, which is, I don't like this bump or growth. And then there are investigational ways of detection with either antibodies, serum testing, antigen, or devices, for example. So this is a little busy, but the melanoma screening, really the USPSTF in 2016 said there's not enough data to recommend population-based screening in the United States. That being said, screening, and so the reason for that is because screening and detection rates have not necessarily lowered rates of unfavorable tumors over the past few decades. As the melanoma incidence has gone up, we're really seeing an increase in the thin melanomas or melanoma in situ. And so that hasn't really made an effect in terms of prognosis or reduced the death rate. There were a couple of screening observational studies that have been done in the past, one out of Germany, where basically 3/4 were non-dermatologists. And at 5 years, the melanoma mortality rate was reduced. And this was just sort of like an all-comer screening program, but longer-term follow-up did not reduce the mortality reduction. It didn't persist. And so other studies have shown that, for example, primary care clinician screening has identified a tumor thickness on average of 0.55 thinner than waiting for the patient just to present. And then another program, screening out of Australia, showed that screened patients were at 14% lower risk of melanomas over 0.75, and that's certainly a threshold that increases the risk for lymph node involvement. Self-screening, I often recommend patients do self-checks and partner-assisted exams because, especially with patients with a history of melanoma, that activity has shown a 42% reduced risk of advanced melanoma. But the absence of evidence is not evidence of absence, and so certainly the fact that we don't have a great study showing screening is going to reduce the death rate, for example, doesn't mean that number one, it's not real, and number two, that we shouldn't certainly identify patients who are at high risk and try to funnel them into the right mechanisms or clinics to identify potential malignancies. And again, these are those risk factors. And so my suggestion is sure, we can't just have broad screening for the entire population, but patients with a risk factor, they should get into the office, especially over age 18 or 20 at least one time. And to get into the dermatologist, I would suggest. And then if based on the evaluation, then the dermatologist can help with the primary care sort out, the frequency at which the screening can occur. In terms of detecting melanoma during either screenings or self-screenings or partner-assisted exams, there are these kind of three main detection programs. One is the ugly duckling sign. If you're not familiar with that, it's basically saying which growth on the body doesn't quite fit in, and that may mean it doesn't fit in because of a color change or increased growth. Let's say something about the pattern of it just doesn't quite fit in with the other growths on the body. And so that ugly duckling sign is actually probably one of the most important signs that I rely on, actually. We went over the ABCD criteria already, and then there's the Glasgow 7-point checklist as well that you can look up. I won't go into investigational, but there are sort of AI and imaging devices that are being generated. And then I just wanted to show a bunch of pictures that, so once these people are, so official screening maybe doesn't necessarily make sense, but you have patients in your office and you're listening to their carotid for a Brewy, for example, and you see this thing on the neck, like don't hesitate to send that in. I think this patient was sent in for other reasons, and I said, oh, well, we should take care of that, for example. And this was a melanoma in situ. And when you're listening to, obviously some of this is different right now because we're doing a lot of telehealth. But certainly, when you are seeing patients in person or down the line, when God willing, coronavirus is gone, then you're listening to their back. Maybe instead of doing it over the shirt, you kind of lift up the shirt and you can just take a peek because here you have another melanoma in situ sitting there. On the Zoom calls, you'll be seeing people's faces a lot, and here's an example of a melanoma in situ on the cheek. And then sitting next to a keratosis, another melanoma in situ. On the back here, again, this is an atypical, darker pigmented growth. This patient's obviously sun damaged and has actinic keratoses and lentigines and photo damage. But there's something about as your eyes are coming down, there's something that obviously sticks out here. That was an invasive melanoma. This patient presented with an unfortunate deep nodular melanoma on the arm. And same thing with another rapidly growing, at least 10 millimeter in depth melanoma on the arm. Just to note here too, this is a growth that has no pigment. So this would be an amelanotic nodular melanoma. And so, growths that are changing that don't have pigment in them, that doesn't necessarily mean they're not a melanoma. Sometimes they're really subtle. And so, there's this light tan pink macule on the shin. And you could sort of say, oh, well, maybe it's a sunspot, and maybe it is, but sometimes, especially if it stands out, it's in the background, not having a lot of other sunspots, that stands out. That's an ugly duckling. Same thing, this patient has sun damage on the lentigines, but again, this is darker, it stands out, it's larger, has multiple colors, and that needs a biopsy. Similarly, you can see again, chronic sun damage changes with dilated blood vessels, sort of this atrophy of the skin, a lot of sunspots, lentigines. And as you're coming across the patient, you move down, and this just stands out. It's dark, it's by itself, it's isolated, has a different color, the shape's a little irregular. Melanoma. This obviously is two tones that should stick out to anybody. And look at the size, how large it is. You can see these other spots. These are either lentigines or keratoses, and they're similar, but this one stands out. Obviously, a pigmented growth on an acral site or a toe that stands out. But I'll just mention, you have to look. I had a patient who I saw last week who probably had a melanoma on the foot for years and wasn't paying attention to it. And now it's at least over 3 millimeters in depth, and that's going to potentially lead to a positive lymph node sample. Obviously, this is something that needs to get looked at, an ulcerated growth. But again, on the side of the same patient, there's a larger atypical darkly pigmented lesion, and that was an MMIS. Again, chronic sun damage patient. I mean, to be honest, this sort of stands out as you come across, that there are lots of lentigines, but as you come across, something about the context or the color is changed, It's more collected, it's a larger spot, and this was a melanoma in situ. Another subtle lesion on the cheek. Again, it stands out though. Like, why does that person have a single sunspot on their cheek? It stands out. And that's another desmoplastic melanoma here. Here on the back, this is actually an atypical nevus, but the one on the bottom was an invasive melanoma. And so then I'm not always saying it's easy. This is a patient who's got tons of sun damage and moles, but at the same time, it makes sense to send this person into dermatology given the increased number of moles and that several stand out. Again, I mentioned the amelanotic melanoma, so you have to be kind of aware of that. And certainly patients with bands in their nails, especially when they have multiple shades in them or they're wider than 3 millimeters, or probably over age 50 and onset, then that's something that needs to get looked at too. So just to summarize, prevention, it's really about limiting ultraviolet radiation, however you're going to do that, and recommend that to the patient. And then in terms of detection, you guys are the first line in primary care to identify who's high-risk groups. Send the ones with multiple risk factors for screening. Educate yourself on what melanomas can look like, and also how to just talk to patients about sunscreen. Keep your eyes peeled. And so again, when we're starting to see patients more in the office, maybe take that shirt off when you're listening to their heart or lungs. And if there's any concern, we're always very happy to take a look. And of course, early stage melanoma, which is what we're trying to do, is find melanomas at an earlier stage. It has a better prognosis. I want to thank you, and I'm very happy to take any questions that John has lined up for me.
Thanks, Michael. And if you have any questions, you guys can feel free to put them in the chat box or shout them out. Let me start you off with just 2 quick questions because we do have a few minutes. The first thing what struck me is how do people know what that proper amount of sunscreen is? Can you give a real world kind of assessment of what two centimeters? What was that? 2 milligrams?
2 milligram per centimeter square. I'd say a lot. It's really like the amount is like slathering it on. I think that the example for your body is basically like a shot glass.
The whole body.
A shot glass for your whole body is sort of the amount that would slather on.
Yeah.
Yeah.
And are you a fan of the spray can ones, or do you feel like that limits the amount of spray there? Or no comment?
I would say officially, I think the sprays are probably not as good, but unofficially, I use them on my kids because they're easier. And so, yeah.
And then the other adage that we all grew up with as residents, and those of us who do biopsies, is never shave a pigmented lesion. Although I heard you comment you've done a few shaves on these. So is that adage out the water, or how does that work, or what's the word?
I think that adage is kind of out of the water. I'd say that for lesions that are atypical, but they're not suspected to be like nodular or deep for however you're going to interpret that shaving it is actually preferred in a lot of ways, because the pathologists actually prefer to get the breadth of the whole specimen than a small punch of a larger lesion. So if you've got a 1 centimeter lesion and you've only got a 4 millimeter punch in your office, it's better to shave that thing to underneath it and get all the way around it so that the pathologist has the whole breadth of the lesion as opposed to a small sampling from within. Now, I'll say that, then you've got those nodular lesions, sometimes actually just doing an incisional biopsy, taking out the scalpel, cutting it out, getting depth makes sense. And it just varies. Like the patient I mentioned last week on the foot had this, large, probably 5 by 3 centimeter atypical pigmented patch on the foot, but within had I think a 1 centimeter nodule. So obviously this is looking like a melanoma. And so, what's the best way to sample that? I actually did a punch at the deepest section, knowing that that was the area that I was going to get maybe the highest or the deepest area in terms of the prognostic information, but also would just confirm the diagnosis.
All right, a couple other questions. Any specific over-the-counter sunscreen favorites to recommend? And you did say you had no commercial interest when you started the talk. So just
That's true. I don't have any interest. I usually answer that question and tell patients whatever they like that they're going to use. I happen to like the no-ad brand just because, again, when patients are buying an expensive sunscreen, then they're not necessarily going to want to use it in the amount that they should to get the SPF protection. And so no ad is relatively inexpensive in the dollar per, I think, gram or cc, whatever it's sold as, amount. They do make various types, including like I think a mostly zinc-based or physical blocker, or like a kid's version. For kids, I don't know, what do we have at home? I like the Blue Lizard, the kids version. You know, but I don't mind looking white, like good pasty. I don't mind looking pasty, sort of, you know, but some people don't like that.
What about, next question was, does the type of clothing matter, cotton versus synthetic?
I would say, I don't have a scientific answer to that question, but certainly what's been shown with clothing is the density of the weave and the color of the fabric. So the darker the color, the more dense the weave, or whatever the material is, the more it's going to absorb. I know that there are fabrics that are like, you know, UPF rated, and I'm not sure I buy that any more than just, you know, fabric that's, you know, has a dense weave and a dark pigment to it.
And there's one more of basically what you were saying from Dr. Phillips. He's asking, the best zinc brand that rubs in well. I always look like a ghost when I use this stuff. So do you have any favorites in that realm?
I think in general, you're using a physical blocker and they're gonna look kind of white, like pasty. Yeah, I mean, you can just, so I don't have a great recommendation for that, because I think in general, that's how it's gonna work. And so, yeah.
And then there's one more, reliability of recommendations from the Environmental Working Group on sunscreen. Lots of parents are asking about toxicity for kids. So basically stick with the zinc and titanium? Question?
Yeah, I think zinc and titanium, especially for concerned parents, makes the most sense. And I think based on the absorption data, I think that's real. Again, I would say the flip side is that we don't know if there's any clinical relevance of that absorption, but to be the most, you know, cautious, I think the physical blockers make sense.
Thanks, Michael. I want to let people know I showed the CME screen again. We will try to get this up on YouTube and get that link out as well for your colleagues who have missed it, or if you want to watch it again. And I want to tease next week's. Will be Rick D'Angelo will be giving an Epic update, also talking about the storyboard changes and some other changes coming to Epic. And of course, I'm hoping for a robust question and answer scenario. He does answer a lot of questions right on the fly. So feel free to kind of lunch and learn with us next week. Everyone have a nice week, nice weekend. It's supposed to be nice. Thanks, Michael, again. Take care.
Thank you, everybody. Thanks, John.